Everybody high. Recent landmark studies such as Reboot, CNILC, and Betamine block have challenged long-standing assumptions about the role of beta blockers after myocardial infarction MI, particularly in patients without significant systolic dysfunction. These pragmatic trials were designed to maximize generalizability, but their conclusions may be incomplete, if not misleading, because they did not adequately integrate both broad, real-world evidence and targeted, physiologically informed approaches. Pragmatic trials, strengths and limitations. Large pragmatic trials are invaluable because they capture a wide spectrum of patients, reflecting real-world practice and guiding population-level recommendations. However, this inclusivity comes at a cost. Important physiologic differences, such as baseline heart rate, autonomic tone, or key comorbidities, are often overlooked or averaged out. The result is evidence that is generalizable but not finally turned to the patients who might benefit most or be harmed most by beta blocker therapy. The role of targeted studies. By contrast, targeted trials focus on select patient subgroups defined by clinical or biological markers such as resting heart rate, sympathetic activity, or even genetics. These studies reveal where drug effects are most pronounced and where risk-benefit ratios are optimized. Ignoring this kind of evidence or failing to embed subgroup analysis into pragmatic design risks obscuring clinically important treatment effects. What was missing in beta blocker studies? Had the major beta blocker trials incorporated physiologic thresholds, such as minimum heart rate or sympathetic activity levels as inclusion criteria, their conclusions would likely have been sharper, more actionable, and better aligned with individualized care. This does not diminish the value of pragmatic evidence, but highlights the need to balance a path forward. The neutrality or modest benefits reported in recent beta blocker trials may reflect not an absence of therapeutic value, but rather a failure to balance breadth with precision. Future trial design should embrace both pragmatic evidence to establish overall safety and effectiveness across diverse populations, targeted evidence to define high-yield subgroups and refine individualized treatment. And conclusion. For beta blockers and indeed for all cornerstone therapies, future research and guideline development should move beyond the felt choice between pragmatic and targeted studies. Instead, they should integrate both, producing evidence that is not only widely applicable but also precise enough to guide tailored clinical decisions. Thanks for likes and sharing.